online. I hope you all can see my screen now. Please type yes in the chat box if you can see my screen, guys. This is the first journal club of this year, and I am very happy to see you all here. I've already made this full screen. Just a minute. Great. Yeah, so I hope all of you can see my full screen now. I'm going to just make some of you co-hosts, so bear with me for a moment. Yup. So welcome all of you to the 69th Pain Journal Club. We have with us wonderful speakers and some great faculties as well. So the topic for today is MSK Ultrasound continued, and we are focusing on myofascial pain in these papers. Of course, pain medicine world over has got diverse issues and variable standards, and of course, different learning requirements as well. As a result, there are different offerings in different places. However, the basic standards, they never change. Time and money prevent most physicians from learning about this wonderful subject. And Mumbai Pain School is an initiative of Panisha Spine Wellness and Pain Lift Center. To overcome these issues, we thought that we'll just focus on online education to begin with. So we focused on Facebook, Instagram, Twitter, and other relevant online media. Most of our content is online, on demand. We have both free and paid content. Most of our content is free. And we, of course, have hands-on workshops. We're very fortunate to have expert faculties from all over the world. It is said that the best teachers, they teach from the heart and not from the book. Journal club, it's nothing, just a club where instead of singing and dancing, we focus on and critically evaluate recent academic literature, which is focused on a defined subject. And of course, attendee participation is most important. So we encourage you to ask questions. Those of you who are watching us live on Facebook and YouTube as well. So I'll be just pushing in the questions which you guys asked to the faculties and speakers. So be free with your comments, suggestions, questions altogether. It is tough to be regular, so try to attend this each time. I see new faces every time, and new names every time. Try to be regular. It's very, very tough. I must appreciate. Journal clubs are important. Even Harrison had his own journal club, which he used to conduct twice a month for critical evaluation of the academic literature. We value the time of our viewers as well as all of us. So please stick to the timelines. And healthy skepticism or praise is most welcome. So feel free to just comment or post up any question. This is a bit about me. I'm a pain physician working in Mumbai. And today we have with us our distinguished faculties, Dr. Amod Manocha, who has done scores of degrees, qualifications. I have never seen a more decorated guy than him. He's the current head of pain management services at Max Hospitals in Delhi. He's also the director of International Pain Center in Delhi. He is the Pain Fellowship Program Director at Max Institute of Medical Education, Max Hospital, Delhi. His area of interest include MSK pain, diagnostic ultrasound, scanning, ultrasound guided pain interventions, neuropathic pain, education, and teaching. He's here with us, Dr. Amod. I have made you the co-host, I think. Yes. So welcome, Dr. Amod. We also have just a minute. Sir, you can say hi to all of us. I think I'll just allow a moment and pause and make him a co-host. Just a minute. Sir, I have made you the co-host. Can you Just say hi to everyone.
Hi everyone. Thank you, Sidharth, for inviting me. It's a pleasure being here.
Thank you, sir. So we also have our second faculty, who is Dr. Akhil Bhalla. He's done his fellowship in pain management, and he's currently assistant professor and in charge of pain medicine at the Department of Anesthesia and Pain Medicine at Adesh Medical College at Ambala. He's founder and consultant at Pinnacle Advanced Pain Management at Chandigarh, and he's visiting consultant for multiple hospitals across the Chandigarh Tri-City area. Welcome, Dr. Akhil.
Thank you, sir. Thank you for the introduction.
Okay, so now over to the first speaker, Dr. Neel. I'll stop my share. You can start sharing. I've already made you the co-host, and you can just start sharing. Put up your CV slide, and I will just introduce you to everybody. Yes, I can see your full screen. Can you? Yeah, thank you. So Dr. Neel OKA has done his MD and DNB in anesthesiology from Solapur GMC, Maharashtra, and he's currently the fellow in pain medicine at DYPU University at Navi Mumbai. So over to you, Dr. Neel. You can start your presentation now.
Good evening, everybody. I will start with my presentation now. The topic of today's journal is effect of visual feedback during ultrasound-guided hydrodissection for myofascial pain syndrome. This is an exploratory prospective observational clinical trial on expectations for treatment. The study was published in Front Psychiatry Journal on 22nd August of 2022. It was done by H. Hasso et al. And it was done in Department of Psychosomatic Medicine, Kansai Medical University in Japan. A little bit about introduction. The myofascial pain syndrome is a non-inflammatory syndrome that presents with symptoms of muscle pain and limited range of joint motion. Clinically available treatments for MPS are trigger point injection of local anesthetic, dry needling, manual therapy, physical exercise, and self-myofascial release. MPS occurs in about 11.9 to 45% of patients who complain of back pain. And ultrasound-guided hydrodissection has recently been receiving increased attention as a therapy for treating myofascial pain syndrome. In USG-guided hydrodissection, doctors use ultrasound to inject a drug solution into the interfacial space at the site where patient feels the most severe pain. A visual feedback during ultrasound-guided hydrodissection is expected to be effective as psychosocial approaches whereby patients raise their expectation for treatment through real-time viewing of their ultrasound image while receiving the hydrodissection. Expectations for treatment have a favorable effect on subsequent course and behavior in these patients. So aims and objective of the study were to explore the possibility that visual feedback immediately after hydrodissection increases the expectation for treatment, which could be one of the related factors for pain reduction. The methods. The inclusion criteria for the study were outpatients who received ultrasound-guided hydrodissection for MPS of upper back, and MPS was diagnosed based on the following criteria. A tender spot located with palpation with or without referral pain, recognition of symptoms by the patient during palpation of tender spot, and at least 3 of the following. One of the muscle stiffness or spasm, limited range of motion of an associated joint, pain worsening with stress, and palpation of taut back or a nodule associated with the tender spot. The exclusion criteria of the study were patients who are younger than 20 years and patients who had any comorbid psychiatric disease or condition that made communication difficult, such as cognitive impairment or delirium. In methodology, this was an exploratory prospective observational clinical trial that explored effects of visual feedback during ultrasound-guided hydrodissection. Visual feedback was defined as hydrodissection administration while patients viewed the ultrasound image with their doctor. Expectations for treatment were set as mediators of pain using path analysis. For hydrodissection, 5 ml of saline per injection were administered by doctor at each institution to 4 bilateral upper and lower sides at the boundary between levator scapulae and trapezius muscles. Doctors used ultrasound to confirm the following points in real time, which were boundary between levator scapulae and trapezius muscle, the position of the needle tip, saline injection, and removal of the fascia. Before starting treatment, doctors verbally explained the ultrasound-guided hydrodissection procedure to the patients. Patients were then asked whether they would like to request view of real-time ultrasound image during the procedure. Patients who viewed the real-time ultrasound image were defined as visual feedback group, and the patients who did not view the images were defined as non-visual feedback groups. After ultrasound-guided hydrodissection, patients were instructed to perform 2 3-minute sessions of self-stretching exercises per day, and assessment were carried out by doctors in outpatient department only at 3 different points in times. One was before intervention, T0, at the day of the hydrodissection, T1, and 14 days after the hydrodissection, that is T2. The results were seen under the headings of clinical demographic characteristics. The second point was measure of expectation for treatment and criteria for increased expectations. Expectation intensity was determined using a numerical rating scale to assess expectations for treatment, which ranged from 0 to 10. That was the highest expectation. The questionnaire was self-administered and contained the following questions, such as, how well do you expect this treatment to reduce the pain? And third point was measures of pain intensity and criteria for pain reduction. The pain intensity was assessed using an 11-point NRS for pain, which ranged from 0 to 10, 10 being the worst possible pain. This questionnaire was also self-administered and contained the following question. How intense was your average pain over the past 24 hours? For patients with multiple MPS sites, the average of pain NRS scores were used. The criteria of pain reduction was determined as more than 50% improvement in the pain NRS score after the intervention. The primary endpoint was the numerical ratings score to assess the expectation for treatment immediately after the ultrasound-guided hydrodissection with and without the visual feedback groups. And the secondary outcomes were proportion of increased expectations immediately after hydrodissection, NRS score change for expectation for treatment and pain, the proportion of pain reduction at T2 after hydrodissection, cervical range of motion, and correlation between increased expectation and pain NRS reduction using path analysis. Results and discussions. A total of 136 patients were selected as study participants, out of which 47.8% received visual feedback during ultrasound-guided hydrodissection. The VAS score for back pain at the first day of surgery was higher than that before surgery in both groups. This table shows the difference between the visual feedback group and a non-visual feedback group. In visual feedback group, the NRS assesses the expectation for treatment at T0, which was 5.7, and which increased up to 8.4 at T1. The proportion of increased expectation immediately after hydrodissection was 90.8% in the visual feedback group, and which was 38% in the non-visual feedback group. The results. Compared with the non-visual feedback group, the visual feedback group had higher expectations for treatment immediately after hydrodissection, and higher expectations were maintained at T2. There was significant difference in time course between the two groups at T0 and T1. The visual feedback group, the 67.7% of patients showed improvement in pain numerical rating scale by 50% or more at day 14, whereas such improvement was observed in only 36.6% patients in non-visual feedback groups. In both groups, all measures of cervical range of motion improved over time, but there was significant difference in time course between the two groups for right and left rotations. The final model to fits the data well. The visual feedback had the most influence on NRS reduction at T2, the beta value of 0.356, and furthermore, visual feedback had the greatest influence on pain reduction at T2, indirectly due to increased expectations for treatment after ultrasound-guided hydrodissection as a mediator. The R-square value, which is overall fit for the model, was 0.298. The discussion part. The first critical point of the study was positive effect of visual feedback during ultrasound-guided hydrodissection on expectations for treatment. 15% of psychosocial approach effects have been attributed to placebo effects, which depend on patients' expectation for treatment. In the visual feedback group, patients' expectation for treatment increased significantly immediately after the intervention. Expectations for treatment increased through awareness of vision during ultrasound-guided procedure. In the visual feedback group, the cervical range of motion for rotation significantly improved in patients who were instructed to perform self-stretching exercises. However, the other measures of cervical range of motion, flexion, extension, and lateral flexion, did not differ between patients who were and were not instructed to perform these exercises. The second critical point was the expectations for treatment could be one of the determining factors for pain reduction. One study reported that more than 50% improvement in pain NRS score was observed in 48.8% of cancer patients with MPS 1 week after receiving trigger point injections of local anesthetic. In author study, they observed 67.7% improvement rate in visual feedback group, which is higher than the above mentioned study. So visual feedback had no direct effect on subsequent course of pain. However, it had an indirect positive effect through increased expectations for treatment. Author speculates that a placebo effect on pain in MPS patients was exerted by patients' expectation for treatment. The visual feedback group, the immediate increase in patients' expectation for treatment after the intervention increased, and adherence rate of subsequent self-stretching, which resulted in MPS pain relief 14 days after the intervention. The path analysis revealed a low adjusted R square value at 0.298, which measures the overall fit of the model. In other words, visual feedback and increased expectation explain only 30% of the pain reduction due to increased expectation is the only one among the several other factors associated with pain reduction. The conclusion, visual feedback during ultrasound-guided hydrodissection increases expectations for treatment immediately after hydrodissection, which could be one of the related factors for pain reduction in patients with myofascial pain syndrome. The limitations which were accepted are the self-selection bias was present because visual feedback group was not allocated. It was selected by the patients. The hydrodissection is a new treatment and has not been established as standard treatment for MPS. Results may not generalize to general population because there were large proportion of cancer patients in this study. The study did not investigate whether there was difference between groups in awareness of recurrent pain due to spread of injected or interfacial space, which may provide patients expectations. The timing of maximum effect and disappearance was obscure because of 2-point test, that is the day of the procedure and 14 days after intervention. And the effect repeated visual feedback effect was not known because of a single session. The critical analysis of this study, the positive point about this study is it encourages incorporating visual feedback during ultrasound guided hydrodissections, and some negatives are the study's predominant inclusion of cancer patients limits its generalizability. The study's short-term focus, that is only up to 14 days after intervention. And the path analysis suggests that visual feedback and increased expectations account only for a portion, that is 30% of observed pain reduction. The take-home message that is visual feedback boosts expectation of patients, the pain reduction post-intervention, the indirect pain relief through the expectations, and future research is needed. Thank you.
Thank you, Dr. Neel. Dr. Amod and Dr. Akhil, if you allow, will ask all the questions in the end together. That'll be fine. We'll go with the second presentation.
Sure, sir.
Yeah, sure. No problems. Definitely.
Thank you, sir. Okay, so over to the second presenter. Thank you for the nice presentation, Dr. Neel. Now I'll request Dr. Mahmoud to please start sharing the screen. I have already made you the co-host.
Hello?
Yeah,
Yes,
I can see you, but not the screen. When the screen is visible, I'll tell you.
The screen isn't active.
Not yet.
You share that. Okay.
Yeah, now I can see your screen. Can you make it full screen and put up your CV
Yes.
slide?
Okay. Okay, sir.
Not yet. Can you?
Just
I think there's some issue. I cannot see your screen. Can you make it full screen?
Okay, sir.
You can see a big black box, but not the. Yeah, now I can see full
Okay.
screen. Can you put the next slide?
Okay, sir.
Thank you. It's the last one. Yes, I will use you. So, guys, welcome Dr. Mahmoud Al-Jabri. He's done his MD and he's a specialist in anesthesia as per the Jordan Medical Council, and he's the anesthesia specialist at Ibn Al-Haytham
Al-Haytham.
Hospital. Yes, and the head of department at JFMH.
Jordan, Finland
He's
Modern Hospital.
great, and he's a fellow in pain medicine at DYPU University in Navi Mumbai. So over to you, Dr. Mahmood. Thank you.
Okay. Hello all. Good evening. Now we'll start about the introduction for the myofascial pain syndrome. As introduction, myofascial pain syndrome, it's a chronic non-specific neck pain, which is the most frequent reasons for medical consultation with the primary care and pain clinics. And it constitutes of more than 90% of cases and present with peculiar symptoms and signs, like the restriction in the active or passive range of motion of the cervical spine together with local or referred pain. The myofascial trigger points considered as the hallmark of myofascial pain syndrome, which is a palpable hard nodules hosted inside taut bands of skeletal muscles. Cervical MPS is mainly based on clinical examination through manual identification of the myofascial trigger points within the target muscles. On ultrasound sonographic view, we can see a hypoequic nodules with clearly defined edges and heterogeneous internal ecotexture is the classical sonographic aspects of the trigger points. Aims and objectives. Review the scientific literature pertinent to both ultrasound assessment of cervical myofascial pain and ultrasound guided procedures. Materials and methods. The materials that use is anatomical and histological biochemical and sonographic features of myofascial trigger points was performed. The second phase, focusing on the cervical myofascial pain syndrome, and the third phase, a pain generator-based approach for ultrasound-guided procedures in cervical myofascial pain syndrome was proposed. The methodology was combining the result and discussion section in order to provide a step-by-step approach to cervical MPS with every pain generator involved in cervical MPS and the corresponding interventional techniques. And in this table, they put the pain generators as myofascial trigger points or peripheral nerve or deep fascia, and the ultrasound guided procedures for each. For myofascial trigger points, we use injection, dry needling of the hypoequic painful nodules, and for peripheral nerve, we use interfacial planar block, and for the deep fascia, we use facial hydrodissection. And on the right side of the table, we see the multiple back and forward needle movement and fan-like maneuver for the myofascial trigger points, high volume distension of the interfacial plan for the peripheral nerves, and seeding technique and optimization with high dose of medication and fluid for the deep fascia. Results and discussions. Myofascial trigger points complex. Multiple elements. And what's the myofascial trigger points complex? It's anatomical and functional connected to each other. Structural changes of the muscle fibers and endomysium are both considered the main histopathological features leading to macroscopic abnormalities of the muscle ecotextures with the development of well-known hypoequic nodules. By the use of MRI on T2 weighting, we change hyperintensity signals, which can be detected as intracellular edema. The clinical effects of massage or performing ultrasound-guided dry needling with multiple back and forward movement of the needle using a fan-like technique could be partially related to the squeezing drainage of extra water bound to the glucose aminoglycans within the intracellular matrix of the painful muscle area. And on sonography, the typical pattern of myofascial trigger points under ultrasound, as we said before, it's a hypoequic area with heterogeneous internal texture. We start the sonographic assessment from wide sonographic scan of the painful area in panoramic view of both the superficial and deep muscle layers. Tahiri et al. Reported a sensitivity of 91% and a specificity of 75% for ultrasound imaging to identify myofascial trigger points within the upper fibers of the trapezius. De Silva et al. Found 100% agreement of intra-rater reliability and 90% agreement of inter-rater reliability as regards grayscale assessment of myofascial trigger points in the upper trapezius. Here we can see the presence of nodules of myofascial trigger points in the upper fibers of the trapezius muscle, and here we see it more deep and see more deep according to site, and it has multiple morphology like round, elliptical, or round shape. And in this figure, we see that the needle entrance back, inward, and outward for the treatment and as the ultrasound guided the procedures. And in this one, we see like the fan-like maneuvers for the procedure of treating of myofascial trigger points. And in this one, we see like hydrodissection with separation of the cutaneous tissue from the muscular layers. The probe can be gently tilted to avoid fake hypoechogenicity of the muscle tissue related to the anisotrophy artifact. Thin septa of the connective tissue widely ramified within the muscles can make the peripheral boundary of the myofascial trigger point cloudy. The P-mode evaluation should be coupled with power Doppler imaging for each and every patient in clinical practice to avoid unintentional collateral injury. Always performing a precise sonopalpation of the hypoequic nodule to verify if the local or referred pain of the patient can be reproduced exactly. In this figure, we can see the spinal accessory nerve, which is located between the upper fibers of the trapezius muscle with the levator scapulae muscle. And here, when we activate the color Doppler ultrasound, we see the superior spinal accessory nerve and the superficial and deep transverse cervical arteries. And in this figure, and in A and B, it's a longitudinal approach for the sonographic assessment for the site of the trapezius and levator scapulae muscle. And when in transverse lie, we can see the dorsal scapular nerve and dorsal scapular artery, which is lying between the rhomboid muscle and intercostalis muscle, which is medial to the medial aspect of the scapula. Fascial structures and the neural elements. We have superficial and deep fascia, which is a two fascial structures are richly innervated by free nerves ending A delta and C fibers, and they play a pivotal role in genesis of cervical myofascial pain. The peripheral nerves, which is the most commonly involved in cervical myofascial pain syndrome, are the spinal accessory nerve and the dorsal scapular nerve. Cutaneous branches of the dorsal rami of the spinal nerves, four main segments of the cutaneous branch of dorsal rami of the spinal nerves at the level of the cervical spine, intramuscular, epimuscular, and infrafacial and extrafacial. Here there is an anatomical draw show us the cutaneous branch of the dorsal rami of the spinal nerves, representing the muscles and the aponeurosis, and the component of the trapezius muscle and rhomboid muscle and the levator scapula muscle. The ultrasound guided procedures. We have three parts of the ultrasound guided procedures, which is injection and the drying needle of the myofascial trigger points, interfacial plane block, and facial hydrodissection. The injection or dry needling, we use a linear high frequency ultrasound transducer by using a plane technique to clearly visualize the needle for its whole length during the entire procedure. The efficacy is mounted by the combination of the pharmacological effects of the anesthetic and the mechanical washout of the sensitizing substances. In interfacial plane block, injections of interfacial plane can be performed to selectively block specific peripheral nerves between the different muscular layers of the facial spine by using high volume rather than a few millimeters to open the interfacial plane. Multi-target techniques to manage a myofascial upper back pain, which is blocking the spinal accessory nerve and dorsal scapular nerve through the interfacial hydrodissection and injecting the trapezius, levator scapular, and rhomboid muscles simultaneously. Facial hydrodissection. Normally, the deep fascia presents a hyperequic fibrillar texture, but in pathological conditions, it becomes hypoequic, focal thickening and delimitation, and perifacial effusion. Hydrodissection of the deep fascia considers an advanced interventional technique that simultaneously targets the interfacial free nerves ending and the perforating cutaneous branches alike. Here we can see the upper fibers of the trapezius between the subcutaneous tissue. There is a fibers, there is hypoequic regions, which is a diseased fascia. And in this one, we see the cutaneous branch of the dorsal rami running between this fascia and the hydrodissection, which is the needles, with the huge amount of fluid as hydrodissection technique. The conclusion: cervical myofascial MPS is a very common but quite challenging clinical condition. In this review, the authors proposed a ready-to-use guide in the clinical practice of musculoskeletal physicians. It is a generator-based approach to describing the different ultrasound-guided interventions while targeting the neuromyofascial cervical tissues. Limitation accepted. The complex interactions between several tissues as Ben generator as the level of the cervical spine. The morphology of myofascial trigger points is highly variable. There is a spherical, elliptical, and pan-like shapes. Clinical analysis. The points with stepwise approach for better evaluation and management of cervical myofascial pain syndromes. Focus also laid on non-myofascial trigger points as pain generators. Asymptomatic latent trigger points were not mentioned, which is a negative. And that's take-home message: cervical myofascial pain is a very common clinical condition in the daily practice. By using ultrasound in cervical MPS can be accurately locate, evaluate the muscles, the fascia, and neural elements. Thank you.
Thank you, Dr. Mahmoud. Over to Dr. Akhil and Dr. Amod sir for the discussion. So, Dr. Neel, you can unmute yourself or can participate. I'll just highlight all of you. Dr. Mahmoud, you can now end your share screen so that all of us can be on the screen now. And
Good evening, everyone.
Pull up the
Um,
questions. Yeah.
Good evening, everybody. First of all, a very thanks to Dr. Neel and Dr. Mahmood. They presented very nice articles, and Dr. Mahmood, especially, you covered a very long article very nicely. There are some points that I would like to pick up in Dr. Neel's article. First of all, the authors wanted to present it as a psychological model and, as a psychological therapy for myofascial pain syndrome. And it was not much more about the procedure itself. And considering it based on a placebo effect, which the authors themselves placed it at. Considering that, it was a very nicely put article because it was a psychosomatic model done in the Department of Psychosomatic Medicine in Japan, and it highlights something which we don't usually look at, and that is the effectiveness of a visual feedback of the patient when you are directly sharing images and videos with the patient and he's giving a visual feedback to you. I think which we should apply in all of our practices, which we already do. But I think it is a very good approach, a fresh approach to the same models which we are following. I think everybody who is practicing interventional pain management should be doing the same approach to with their patients. Coming to the paper itself, the authors did discuss myofascial trigger points as a inclusion criteria, but in the procedure itself, they did only interfacial planes hydrodissections, and they did not address the trigger points. They did not do any dry needling for the trigger points, or even mention doing anything for the trigger points first. Only the interfacial plane done. And I think that is my take on this. And I think Dr. Mahmood's paper very aptly covered everything. In fact, they discussed this point itself in their paper that myofascial trigger points are more important, and how to approach and how exactly they've given that table, which is very nicely put, how to approach myofascial pain syndrome patient. That's my take on that. Dr. Motsa.
Hi, sorry, I've switched my video off because the internet's a little unstable. And if I disappear for a few seconds, that's because the internet, I've not run away. Firstly, I would like to say that I think both the papers address a very common problem, which we all see in our clinic. So the first thing which generates interest for me is that it's a common problem which we deal with. And if I can do things, and it's a common problem which we don't handle very well, in the sense we have limitations in our understanding or how we address it and how much success we have. So that's the first thing which generates my interest in both the papers. Then the second thing I would like to say is, especially about the second paper, I read it a while ago, although it's a very recent one. And anything which changes my practice is really appealing for me, right? So the second paper actually addressed a lot of lacunae in my thought process. I'm not going to critique the paper itself, but I'm just telling you how I see this paper. So it changed my practice in the sense that I, after reading that paper, started adding facial plane blocks to my facial pain patients. In the sense, earlier I would just do trigger point injections, but now I routinely add the myofascial plane blocks for the patients where I'm struggling with specially. The second thing which they talk about is how we look at the pain, like the sensory and the cutaneous branches, and how they could be involved in perpetuating this pain, which is very, very important. That's not something I thought about before. Although I have been doing the dorsal scapular nerve and the spinal accessory nerve block for a long time for these patients, because I believe these are the nerves which carry the pain impulses from this area. So I think from the point of view of understanding, the addition of facial plane blocks did make a difference to what I do to these patients, and the outcomes have been improved. So I think anything which changes the practice, which enhances your understanding, is a very important paper. And I would strongly recommend reading that paper if people have not read it. And I would say very nicely selected paper for this forum for the discussion. Regarding the first paper, again, I routinely show my patients the ultrasound screen, provided the logistics and the ergonomics allow that to happen. And I tell them it's like a video game. And I use it to distract them, to be very honest. So they're taken away from the distressing environment and they're focusing on something. Especially the young boys, they find it very appealing. It's like a video game. That's my target, and this is how my needle's coming. But having said that, a lot of them don't want to see it, especially women. Some of them do find it distressing, and if I find there is any element of that, I do not add it. But I would also like to say that the authors have only looked at the placebo effect. But is there a the sympathetic and the parasympathetic system being involved in the whole issue, saying that maybe it is somehow the descending and the ascending system, the balance is altered by reducing the anxiety, and it's not just placebo, but actually there are maybe the chemicals which are active in the ascending and the descending system are being altered by that positive response. So rather than just saying the placebo, it's adding to the confidence of the patients and actually altering the way the sympathetic and the parasympathetic balance is there, and the ascending and the descending balance is there, in terms of improving the efficacy. So there might be more to it. I certainly don't see a harmful effect as long as your patient's not going to faint over it. I don't see a harmful effect. If not anything else, reducing the anxiety and distressing effect is very important thing. And it just takes them away from that environment. And it gives them an end goal that at this point, okay, now the medicine's going and now the injection is going to finish, and that often helps them to put everything in perspective. It's a shame they didn't look at it beyond 14 days. I would have loved to see how in the long term the clinical outcomes are being altered. And I don't remember if they evaluated the psychological profiles of the two groups prior to the study, because that's another important I know the people are volunteering in terms of what they want, but that also might indirectly indicate the profile or their acceptance or their behavior. There might be more to it in terms of the way the personality they have, and that might also have a bearing on the result.
Yeah, thank you, sir, for these comments. Dr. Neel, Dr. Mahmood, you need to make any comment or ask any question, discuss anything?
Just I want to add, sir, there is Dr. Ahmed Nuhu. He wrote in the chat any biochemical markers that may be seen in the MPS.
Yeah, he's asked a question. Yeah.
Yes, I think there is the glucosaminoglycans within the pathological gaps, which is of the endomycin that's when retreating fluid inside the contracted nodes of the myofascial trigger point complex. So the counteract when we wash out of the nociceptive substances and the pro-inflammatory molecules and protons, and these are sensitize the nociceptive of the muscle, which may lead to muscle hyperalgesia, and this is the cause of the pain from the myofascial trigger points complex.
Yeah, you're right. But even in addition to that, the acute inflammatory markers, they are also raised. Now, the significance is still not proven. I mean, how much you can actually use it as a diagnostic marker or maybe a prognostic marker, because those can be raised in many different conditions. But definitely, I have come across some, text saying that this is raised. Dr. Amod, you need to have, say something on this. I mean, if you have biochemical markers. The question
No,
was any biochemical markers of MPS, and that is myofascial pain syndrome or myofascial pain in general, and how we can clinically,
to
use
tell you
it in our practice.
To tell you very honestly, this is something which I haven't done a lot of research about, but I think it's a very interesting thing which we all need to look at. The way the oncology world has moved from genetics into from biochemical markers into genetics. That's something we will see happening in the pain world as well in the near future. And all these things are very, very relevant. But I think in the pain world, the complexities of this are mind-boggling. Having said that, the body is very complex, no doubt about that. But that's something which I am not the best person to comment on. Let me be very honest, because I've not done enough research on this specific to the myofascial pain syndromes. But when I was reading about the, the glycosamine glycans and all those things, I was also wondering when I read this article, I remember a while ago, that I was thinking what probably might be the impact of putting hyaluronic acid into the myofascial planes. And I was thinking I'll look for any articles if there are any to see if someone's done that and if that adds something to it or not. To increase the lubrication, and if that's one of the pathology involved in kind of causing the pain. I don't know. It's just a random thought. Sorry. I don't certainly recommend doing that to your delegates, but I'm saying that's just something which was crossing my mind.
So I think I was studying once on biochemical markers for pain in general, and when studying about that chronic pain, I'm talking about. While studying about that, I was going through literature, and in myofascial pain, they have mentioned about the acute phase pro-inflammatory mediators, and their levels are usually raised, and they even have done some studies, and they found that it was raised, but they could not extrapolate these findings into clinical benefits, like how much they are raised and how we can infer it, whether we can actually give some sort of a prognosis to the patient, or whether at all we can use it for the diagnosis, because there can be many causes for the same thing. When they do a study, they find yes, but if a patient walks into my OPD and he has raised IL-6 or IL-8 or something, then it's very difficult to convince him or convince myself that okay, his middle back pain is due to this or it's a good indicator of that, because it is not specific to a part of the body where the patient has pain. So maybe we can have new insights someday, and then we can actually localize those markers with that pain. Probably that will add some good insights.
So that I'd like to add one more thing. One of the limitations of these studies is that you need a good ultrasound machine to look at this. Having said that, that shouldn't stop you from if you have a decent one or an average one to kind of look into these things, because to train the eye to look into it is always something which everyone needs to do. But yes, the better machine you have, the more the chances you will pick up these small little changes. And that does make a lot of difference. Like I work in two different places, and one place I've got a very basic machine, and the other one I've got a very fancy machine. And when it's the same patient, sometimes I've had the opportunity to look across, and the difference it creates in terms of your being able to identify something or not is huge. And that is a limitation. But I see that becoming as the technology is evolving, that becomes less and less that is becoming less and less of an limitation. But yes, that is something which does influence what people do.
Great, sir. I agree, sir. What you have mentioned. Only thing is that we are coming from a specialty where more focus was laid on procedures, and now slowly we are moving into the diagnosis part as well. And we more and more people are realizing that it is also important to diagnose as well as then, of course, treat the condition. And unless you do both things together and combine it with clinical inputs, you cannot treat the patient. So this is being your point is very well taken, and it's in fact being especially the younger generation, those of us who are just entering into the MSK pain, so they are actually taking a very holistic view of this branch, and that is very encouraging, I think, and heartening to see. So we have one more question, sir. I'd like to take that. This is from Dr. Samriddhi Nanda, and she's asking, would you always see disturbance in the sonographical morphology in the myofascial trigger points?
That just highlights what we were just discussing, the better you machine you have, the more the chances. But having said that, not always, even with the the best machines. But there are other pointers you might get. Like when you put the needle in that area where the patient's saying the pain, you might see a localized muscle twitch, which is very odd compared to other places, which will make you think, oh, was there a trigger point over there? And then when you look closely, you might see something architectural difference or the appearance difference, which is there. But what I try and do is I try and get the patient to pinpoint the most tender spots before I do anything. And I mark them with a permanent marker, and then I scan that area very closely and as carefully as possible. And I would definitely work in that area. And remember, it's always still the chicken and the egg situation. We don't know whether the nervous dysfunction is causing these trigger points to form, or whether the trigger points are forming and the increased firing in the nerves is causing them to malfunction as well. So hence, what the article is saying, combining the two along with the plain blocks is kind of you're trying to address it more comprehensively, and I find that very useful. Especially the plane blocks, like the superficial planes. Before reading that article, I never used to focus on. Deep planes I might still focus on. That's something which has changed. The hydrodissection of the planes, I never used to do that very often unless I have a trigger point in that area. Now I do that regularly when I'm combining with these patients. So I do more and more of these myofascial patients with ultrasound, which I would do previously without ultrasound, without bothering about it, because I actually want to see these facial planes. I want to target these nerves at the same time. And that is what makes a difference in their outcomes. Not with all of them, but yes, it does sometimes work.
Great, sir. I agree. Dr. Akhil, you need to add anything, or Dr. Neel, Dr. Mahmood, anything you guys need to add?
So, even I have recently started doing facial plane blocks, and earlier definitely we were using only dry needling. Hypodermic needling was done when only you could see a very significant trigger point, maybe, and maybe sonographically significant. And I think Sir put it very well that the machine is quite important to even localize such trigger points. That being said, it is quite helpful to do a facial plane block, and it should be done regularly along with dry needling if you want, if you think maybe that it is required. If not, then even dry needling, ultrasound guided dry needling, or even ultrasound guided hydrodissection would be quite helpful. I think it will be on a patient to patient basis. You cannot generalize one therapy to all patients.
Yeah, maybe a thorough scanning actually. If somebody, I mean, some of you at least might be getting the patient repeat for the repeat injection, and you find that now you are well versed with that particular patient's anatomy. The same thing happens if you do a very thorough pre-procedure scan. So then you get to see that particular patient's nerves, and you scan all around, and then we were and this is not only visible in myofascial pain situation, but also when you are targeting peripheral nerves. And recently we were doing some procedures, and we focused on even the peripheral nerves, like even the median nerve and all. And we tried comparing all these, and it's kind of very fascinating how we can personalize the approach, and then it becomes actually therapeutic when you find that, okay, one particular anomaly is a reason for that particular patient's pain. And that is what why the interest of physicians has been sparked in this diagnostic field. So trying to find out the abnormalities, which will be difficult to detect with the help of your knowledge and combination of the clinical symptoms, and then treating them in order to get some good result. Dr. Smriti is asking a follow-up question. Would you still consider doing needling despite not visualizing the disturbance, in sonomorphology? So I think, yes, I will go ahead with it. Dr. Amod, what you will say on this?
I would as well. If there is no other cause which I can put that down to, and I'm seriously considering the diagnosis which I've got, then this is one of the ways I would go ahead. What I also do is I trained in acupuncture a long time back, so I often open my acupuncture book and I combine that the points which will be affecting in that area or that condition. I would do dry needling in that area as well. in these traditional acupuncture points, and those charts and books are very easily available if any one of you had interest. And I've found sometimes, especially with the cervical pain patients, even that has given I mean, like when I opened my clinic in the initial few days, I didn't have an ultrasound and an X-ray over there, so I started doing acupuncture for a lot of them out of kind of I was forced to. And I was surprised. Some of them had 90% plus relief with only 2 or 3 sessions of acupuncture in places done far away, the traditional acupuncture point, which just made me go back to that again. That, okay, it's not only just that area, all these traditional acupuncture points, if I do needling over there, I'm like, it's just the different needles. The concept is somehow the concept is different in the traditional acupuncture, but I found success with that as well. So I would do local points, and I would do sometimes with these far off distant points as well.
Of course, and many of us would agree that many patients think, even though we are doing this needling, and many of them even call that acupuncture. So they think we are actually, so probably that may also have a role in the result. The expectation of patients, that they will get relieved after the procedure will also help. And I think that if we are we are at a position where after big procedures like RF, we are aiming at 50% result, and we are taking it as significant. So if you are getting with the traditional method, you're getting good results, I think definitely it should be part of your armamentarium.
And I
Great.
feel the machine, like we always believe in that machine. We should not be believing in the machine as much as what we feel. So if you can feel the trigger point, if the patient typically says that he feels the trigger point and it is super painful, even, maybe or maybe not on sonopalpation even just on palpation, if you feel the trigger point, it is very helpful to do dry needling,
Yeah, I
irrespective
will
of
not
whether you're
completely
getting
agree to this because probably we are at a very nascent stage. We are just beginning to see these trigger points. I mean, I've been, hearing these talks since last few years only, and we have very good practitioners, who are actually focusing on this area. And I'm sure we'll see much more reliable and much more, in any ultrasound technique, the scanning technique is important. So you go to a fixed landmark, then you move left or right, and then you always have a sequence. So probably that sequence is not very well defined yet. So we are saying that, okay, some of us can see the trigger point, some of us cannot see. So I feel all of us right now are using the same method what Dr. Amod mentioned, that we find the trigger point, the most tender spot, and tell the patient to pinpoint it. Then we mark it, and then you start there, and then try to see what you can find. But I'm sure with time, more with newer techniques, we'll be covering in newer sections. With newer techniques, we can be more objective and less subjective. So I think that would make a change. It is highly operator dependent.
So that's sorry. Also pointing out, like I think I sometimes the more I think about it, the more I believe in this concept as well. The cutaneous nerves being trapped. If you think about ACNES, anterior cutaneous nerve entrapment syndrome in the rectus, we have believed in that for a long time. We've all treated so many patients with that. So if it can happen in the rectus, why can't it happen in a big muscle like trapezius? If it can happen anteriorly, why can't it happen posteriorly?
Right.
Often if I have a doubt, I would scan first the whole area myself before I get the patient to mark it, because it is more satisfying for me if I can identify an area and the patient and I say, is this the area of pain? And the patient says yes. That increases my confidence double, because if my sonoanatomy can identify the area and the patient's pain is corresponding to that, then it is even more satisfying for me and more convincing for me that actually the problem lies over here and this is the area which I need to work on. And then if I can't see anything on my first scan, then I would ask the patient to mark it for me, and then I would work on that. I'm saying this because one of your previous patients was asking about, sorry, not patients, one of your previous delegates was asking about, would you still trigger the area? Would you still work on that area or not? So I'm just adding this as an answer to that as well.
Great. I think this sums it up pretty well. So before we end, Dr. Neel, Dr. Mahmood, Dr. Akhil, Dr. Ahmad, anybody wants to make any final comments?
So we have one more comment, and it says that they tried cupping therapy and it seems helpful for many patients. So I think it is based on the same concept. Even massage helps some patients. It breaks the trigger points somehow, and manual therapy also helps. I think that explains the cupping therapy. And yes, that is also very helpful for myofascial pain. As Dr. Amod said, that even acupuncture is very helpful. It is very helpful, in fact. You cannot definitely generalize one treatment to all patients. You cannot just say ki, if you do cupping therapy and then you'll have relief if even there are significant trigger points. What do you think, sir?
Yeah, I agree. So if the muscle is the culprit, there are all various ways and means to.
Just one more point. I'm dealing with the. Yeah, just one more point. I'm just reminded of this because I'm dealing with this patient currently also. So I've got one patient who's got saphenous neuralgia post dry needling. And that's something to be mindful of, that sometimes when you're over enthusiastic, well, I can't 100% say that it's the dry needling which has done it. But if you're over enthusiastic, sometimes we can also cause harm. So let's just be a little bit careful about what we are doing and a bit more scientific also, if we can be, but by knowing the anatomy and being scientifically in the right area.
Great point, well taken, sir. So I think we thank both the faculties, Dr. Amod, Dr. Akhil, for your time and your valuable contributions. And of course, the speakers, Dr. Neel and Dr. Mahmood, for excellent presentations. And thank you. Thank you, both of you.
Thank you.
Thank you, Sidharth. Very nicely selected articles.
Thank you so much, sir. So now we'll just go to the end of the session, and this was the season 4 of the Mumbai Pain Schools Pain Journal Club, where we are focusing on the MSK Ultrasound, and this time we had a new time, which is 8 p.m. Indian time on Fridays. We have group topic for seasons, and we have 2 faculties, 2 papers each time. And of course, as always, I try to post a paper one day in advance. So the next steps for all of you who are here for the first time, guys, please join our mailing list. I have already posted the link in the chat box, and join the WhatsApp group. Again, the link is in the chat, or you can email me. Any suggestions, comments are most welcome. So just mail them to me at mumbaiPainSchool@gmail.com. And of course, let's meet up next Friday, 8 p.m. And do join us. Those of you who want to do some hands-on, join us on the hands-on MIPSIS workshop, which will be conducted from 26th to 20th April 2024. So with these words, thank you very much. Thank you all for joining in, and we'll see you all very soon. Until then, it's bye-bye, and see you guys around. Bye.